Good morning, everyone. Today we're going to explore the Precaution Adoption Process Model, or PAPM, a stage theory of health behavior change that offers a nuanced framework for understanding how people come to adopt new health protective behaviors. Unlike many traditional behavior change theories that view decision-making as a single step governed by cost-benefit analyses, the PAPM recognizes that behavior change involves a series of qualitatively distinct stages. This insight has profound implications for both research and practice. The PAPM was initially developed by Neil Weinstein and colleagues in the late 1980s and has evolved into a sophisticated framework that has been applied to numerous health behaviors, from cancer screening to osteoporosis prevention, from home radon testing to vaccination. What makes this model particularly valuable is its recognition that different psychological barriers exist at different points in the behavior change process. This understanding allows us to design more targeted and effective interventions that meet people where they are in their decision-making journey. Let's dive into this model and explore how it can enhance our understanding of health behavior change and improve our behavior change interventions. Most health behavior theories, such as the health belief model, theory of planned behavior, and protection motivation theory, take what we call a continuum approach to understanding behavior. They propose a single prediction equation or algorithm, acknowledge quantitative differences among individuals in their readiness to act, suggest that the same variables influence everyone, just to different degrees, focus on identifying factors that increase the likelihood of action for all people, and emphasize a cost-benefit analysis as the central decision-making process. These approaches have merit and have contributed significantly to our understanding of health behaviors. However, they may oversimplify the complex process of behavior change. Stage theories like the PAPM propose a fundamentally different view of behavior change. People move through a sequence of qualitatively different stages. Different barriers exist at different stages. Different intervention strategies are needed for people in different stages. A single prediction equation is insufficient to capture the process. Multiple equations are needed, one for each stage transition. As Weinstein, Rothman, and Sutton back in 1998 note, this is a more complicated approach, but it offers the possibility of greater accuracy, intervention effectiveness, and intervention efficiency. All stage theories, including the PAPM, share four key elements. First, a category system to define the stages. Stages are theoretical constructs with defined characteristics, though boundaries between stages may not always be clear-cut in practice. Second, an ordering of the stages. People typically pass through all stages in order before taking action, though progression is neither inevitable nor irreversible. Third, common barriers facing people in the same stage. Individuals in the same stage face similar barriers to progress, making stage-targeted interventions possible. And finally, different barriers facing people in different stages. The factors influencing movement differ by stage, requiring different intervention approaches for different stages. The PAPM identifies 7 distinct stages that people may pass through when adopting a new precautionary behavior. Stage 1. Unaware of issue. The individual has never heard about the health risk or protective action, and honestly, no opinions have been formed yet. For example, think about a young adult in 1987 who had never heard of AIDS. Stage 2. Unengaged by issue. Here, the individual is aware of the issue but has never thought about their personal response. They know about the issue but aren't personally engaged with it, like someone who knows what radon is but has never considered testing their own home. Stage 3. Undecided about acting. The individual is actively considering whether to take action. They are engaged with the issue and weighing their options. For instance, a woman contemplating whether to increase her calcium intake for osteoporosis prevention. Stage 4. Decided not to act. The individual has considered the issue and made a conscious decision not to act. This is a terminal stage unless new information or circumstances arise. For example, someone who decides not to get vaccinated after considering the pros and cons. Stage 5. Decided to act. The individual has made a firm commitment to take the precautionary action. They intend to act but have not yet begun. An example would be a homeowner who decides to test for radon but hasn't ordered a test kit yet. Stage 6 acting. The individual has initiated the behavior change, and they are actively taking steps to reduce their risk. For instance, a person who has started taking calcium supplements. Stage 7, maintenance. The individual has sustained the behavior over time. For recurring behaviors, this represents ongoing adherence, like someone who has continued to take calcium supplements regularly for osteoporosis prevention. It's important to note that stage numbers are ordinal only and should never be treated as a continuous variable in statistical analyses. Also, stage 4, which is decided not to act, represents a branch away from action rather than a step toward it. Each stage in the PAPM has a distinct theoretical justification. Stage 1, unaware, versus Stage 2, unengaged. If people have never heard of a hazard or precaution, they simply cannot have formed opinions about it. Many survey methods force responses from people who have no opinion, discarding don't know answers as missing data. Media often have their greatest influence in moving people from Stage 1 to Stage 2. Stage 2, unengaged, versus Stage 3, undecided. Many issues compete for people's attention, so knowing about a hazard doesn't mean considering personal action. Media are better at agenda setting, moving folks from Stage 2 to 3, than influencing specific decisions. People who have thought about acting likely have different knowledge levels from those who haven't. Stage 3, undecided versus Stages 4 and 5, the decision stages. Research shows people who have made decisions respond differently to information than those still deciding. Confirmation bias and belief perseverance make people who have decided more resistant to contrary information. Traditional health behavior theories like the health belief model and the theory of planned behavior focus primarily on the factors that influence the transition from Stage 3. Stage 5, decided to act versus Stage 6, acting. The distinction between decision and action is crucial and recognized by most theories. Implementation challenges are distinct from decisional challenges. Implementation information is essential for people in Stage 5, but premature for those in earlier stages. Stage 6, acting versus Stage 7, maintenance. Initial adoption of a behavior differs from ongoing adherence. Maintenance involves different challenges and requires different strategies. Personal experience with the behavior influences subsequent decisions. A series of studies by Blaylock and colleagues provides an excellent example of how to apply the PAPM to a specific health behavior: osteoporosis prevention through calcium intake. Steps in applying the PAPM to develop interventions include: first, identify and define the target behavior. For osteoporosis prevention, researchers focused on calcium intake. This is a behavioral category rather than a single behavior, since adequate intake can be achieved through various means. Researchers define the target behavior in terms of specific daily calcium intake. Second, develop a stage classification system. They created an algorithm to classify individuals into PAPM stages for calcium intake, defined what constitutes acting and maintenance for this behavior, and used the classification system to assess stage distribution in the target population. Third, identify factors influencing stage transitions. Early research found that to move people from Stages 1 and 2 to Stage 3, interventions should focus on increasing awareness of osteoporosis, communicating behavioral recommendations, and highlighting the effectiveness of calcium intake for risk reduction. For transitions from Stage 3 to Stage 5, interventions addressed perceived susceptibility, outcome expectations, and self-efficacy. For transitions from Stage 5 to Stages 6 and 7, interventions focused on reducing barriers to action, building necessary skills and resources, and establishing habits. Fourth, develop stage-matched intervention strategies. They created written materials and telephone counseling protocols, helped women identify barriers to calcium intake, and developed strategies to overcome them. This approach led to significant increases in calcium intake among women in Stages 3 and 5. Fifth, specify evaluation criteria. They determined that success would be measured by both stage progression, meaning movement toward action, and actual behavioral change, or increased calcium intake. Sixth, determine the time frame for assessment. They recognized that behavior change is dynamic and used multiple follow-up assessments to capture both short-term and long-term effects. Key findings from the osteoporosis prevention studies were that different variables distinguished between different stages, supporting the qualitative differences proposed by the PAPM. A PAPM-based intervention increased calcium intake significantly among women who were thinking about or trying to increase their calcium intake at baseline. The same approach was less effective for exercise behavior, highlighting the behavior-specific nature of barriers. Stage-matched interventions were more efficient than generic approaches, particularly for behaviors where barriers vary substantially across stages. A field experiment on home radon testing by Weinstein, Lyon, Sandman, and Kuwait from 1998 provides a really rigorous test of the PAPM's stage-based approach. So, let's break down the study design and methodology. This study tested two key stage transitions. First, from being undecided about testing, which is stage 3, to deciding to test, that's stage 5. And then, from deciding to test, stage 5, to actually ordering a test, which is stage 6. The researchers, developed two targeted interventions. One was a high-likelihood intervention, which focused on local radon risks and refuting myths of invulnerability. This one was predicted to help people move from stage 3 to stage 5. The other was a low-effort intervention, which provided information about test kits and an order form, and this was predicted to help with the transition from stage 5 to stage 6. Participants were homeowners in Columbus, Ohio, a high radon area. They were classified into stages after viewing a general informational video about radon, and then randomly assigned to one of 4 conditions: control, high-likelihood treatment, low-effort treatment, or combination treatment, which included both interventions. Now, let's talk results and implications. The experiment strongly supported the PAPM's premise that, honestly, different stage transitions require different approaches. When we look at stage progress findings, the high-likelihood treatment was significantly more effective for undecided participants than for those who had already decided to act. Meanwhile, the low-effort treatment had a larger effect on people who were already planning to test. Looking at test order findings, people who were already planning to test were more likely to order test kits than those who were still undecided. The low-effort treatment dramatically increased test orders among those who had decided to test, but the high-likelihood treatment alone did not significantly increase test orders in either stage group. The combination treatment turned out to be the most effective overall, but, well, it required twice the time investment. From a theoretical perspective, being undecided and having decided to act really do represent distinct stages. Information about risk is helpful in getting people to decide to act, but it doesn't do much to produce action among those who have already decided. On the other hand, information that increases the ease of action greatly helps people who have decided to act, but is less important for those still undecided. Standard approaches that compare those who have acted with all who have not may actually miss important variables relevant to specific stage transitions. And practically speaking, the stage-targeted interventions produce substantial effects, up to 10-fold differences in test rates. But interestingly, such approaches have never really been used in actual radon testing promotions, which still focus mainly on risk communication. PAPM-based interventions can be more efficient by targeting specific barriers at each stage. The PAPM has actually been applied to numerous health behaviors, including osteoporosis prevention, cancer screening like mammography and colorectal screening, hepatitis B vaccination, home radon testing, smoking cessation, red meat consumption, and sun protection. The types of research you'll see include cross-sectional studies comparing beliefs across stages, longitudinal studies tracking stage progression over time, and intervention studies that test PAPM-based treatments. So, when it comes to common research findings, research consistently shows significant differences in beliefs between adjacent stages. Different variables tend to distinguish different stage pairs, which really supports the qualitative nature of the stages. Interventions that target stage-specific barriers are shown to be effective, and the stage concept has real practical utility for tailoring communications. Of course, researchers face several challenges when applying the PAPM. For interpretation issues, People sometimes misinterpret the PAPM as being primarily focused on risk perception, or they might mistake variables that may influence stages for core model assumptions. Methodological challenges also come up. For instance, cross-sectional data can't actually establish causality between variables and stage transitions. And combining stages for analysis loses the qualitative distinctions that are central to the model. Plus, small sample sizes in some stages can lead to statistical problems. There's also complexity in defining stages. It can be difficult to apply the model to complex or continuous behaviors, and there are challenges in addressing multiple complementary preventive actions. Researchers have questions about how to handle past behavioral attempts, and there's uncertainty about how to classify partial progress toward a goal. So, there are 4 key criteria that should really guide decisions about when to use stage-matched interventions. First up is superiority over unstaged messages. Basically, stage-based interventions should show clear advantages over more generic approaches. We're talking about things like greater effectiveness in actually changing behavior, better efficiency in using resources, and, improved audience engagement and message processing. Sometimes, even if a comprehensive intervention is the most effective, resource constraints might make stage-targeted approaches more practical. For instance, in the radon study, the combination treatment was the most effective, but it required twice the time investment. Next, let's talk about the feasibility of stage assessment. The practicality of assessing which stage someone is in really varies depending on the context. In individual settings, like clinical encounters, it's pretty easy to implement with simple algorithms. In group settings, you can assess predominant stages but not really individual needs. And when it comes to mass media, it's, honestly difficult to assess the stages of audience members. The PAPM only requires a simple staging algorithm, which actually makes it feasible in a lot of settings. Third, we need to consider the ability to deliver stage-targeted messages. Whether or not you can do this depends on several things. For the communication channel, one-on-one communication is easily tailored to an individual stage. Group settings can target the predominant stages, and mass media has pretty limited targeting capability. Though digital media is starting to offer some new opportunities, audience composition also matters. If the group is mostly in the same stage, it's easier to target. If it's a mix, it gets more challenging and might require multiple messages. And, the type of media matters too. Print media offers more targeting opportunities than broadcast, and digital media is really opening up new, cost-effective ways to target specific stages. Finally, there's the difficulty of behavior change. The utility of stage matching goes up as the behavior gets more complex. For really simple behaviors with minimal resistance, the stage may not matter much. But for more complex or difficult behaviors, there's a greater need for stage-matched interventions. And even actions that seem simple, like radon testing, can bring up unexpected questions or barriers that require stage-specific approaches. Recent research has, really continued to advance our understanding of the PAPM. Let's start with some recent applications. Studies have applied the PAPM to contemporary health challenges, like COVID-19 vaccination behavior. The model has been used to understand vaccination hesitancy during the pandemic. Stages were actually predictive of people's ultimate vaccination decisions, and different intervention strategies were effective for those in different stages. There's also been work with cancer screening technologies, especially with newer screening modalities like lung cancer CT screening. The focus here is on moving high-risk populations from awareness all the way to action. Digital health interventions are another area of growth. We're seeing stage-based mobile health applications for behavior change, with algorithms that adapt content based on the user's current stage. Now let's look at some methodological advances. Researchers have developed improved approaches to working with the PAPM. For example, there's measurement refinement, like validated staging algorithms for various behaviors, methods for reliably classifying individuals into stages, and approaches for handling complex or continuous behaviors. On the statistical side, there's latent transition analysis to model stage movements, techniques for testing moderation by stage, and methods for evaluating matched versus mismatched interventions. The PAPM is also being integrated with other theoretical perspectives. For instance, It's being combined with continuum models, using health belief model constructs to understand specific stage transitions, and incorporating self-efficacy concepts from social cognitive theory. There's integration with implementation science too, using the PAPM to understand provider behavior in clinical settings and examining how organizational factors influence stage transitions. Looking ahead, there are some key areas for future investigation. Stage-specific determinants are important, like identifying the most important barriers at each stage across different behaviors, and understanding how these barriers vary across populations and contexts. Digital tailoring is another big one, leveraging technology for real-time stage assessment and intervention tailoring, and developing algorithms that adapt interventions as individuals progress. Cross-cultural applications are also crucial, testing the model's validity across diverse cultural contexts and examining how cultural factors influence stage distributions and transitions. And finally, longitudinal studies, tracking individuals over time to understand natural stage progression and identifying factors that predict forward movement versus regression. So, let's explore how health professionals can actually apply the PAPM in practice. First, there are stage assessment strategies. In clinical settings, you can use brief screening tools that fit right into patient intake, or decision trees for figuring out a patient's stage. For example, you might ask, have you ever heard about calcium for osteoporosis prevention? Have you thought about taking it? Have you decided whether to take it? In community settings, surveys can help determine the stage distribution in your target population, and rapid assessment techniques work well for group interventions. For instance, you could use audience response systems during community presentations. For digital applications, algorithms can assign users to stages based on their responses, and adaptive questioning can refine stage classification. An example would be web-based tools that direct users to stage-appropriate content. Now let's talk about stage-matched intervention approaches. For stages 1 and 2, unaware or unengaged, the focus should be on raising awareness and making it personally relevant. Use media campaigns, community outreach, and basic education. For example, public service announcements about radon risks in high-risk communities. For stage 3, the undecided folks, you want to address outcome expectations, perceived susceptibility, and normative beliefs. Provide balanced information about the pros and cons, and help facilitate deliberative decision-making. Decision aids for cancer screening that present both benefits and risks are a good example. For stage 4, those who have decided not to act, it's important to acknowledge and respect their decision, but also provide new information that might prompt reconsideration. Address any specific concerns that led to their decision. For instance, addressing specific vaccination concerns for people who have declined. For stage 5, those who have decided to act, the focus should be on implementation planning and reducing practical barriers. Give specific concrete action steps and work to enhance self-efficacy for the behavior. For example, provide specific instructions for ordering a radon test kit. For stages 6 and 7, acting and maintenance, provide reinforcement and support for continued action. Address barriers to maintenance and help develop coping strategies for challenges. Reminder systems for medication adherence are a good example here. When evaluating PAPM-based interventions, there are a few things to keep in mind. Multiple outcome measures are important. Look at stage progression as well as actual behavior change, process measures related to stage-specific barriers, and long-term maintenance of the behavior. You also want to think about appropriate timeframes. Allow enough time for stage progression before expecting behavior change, and use multiple follow-up points to really capture the dynamic nature of change. Finally, consider the context. Assess environmental factors that might influence stage movement, and examine how social and policy factors interact with an individual stage. The Precaution Adoption Process Model really offers a nuanced framework for understanding health behavior change, one that recognizes just how complex human decision-making can be. Some key strengths of the PAPM include its recognition of qualitative differences in how people think about health behaviors at different points in their decision-making process, and the identification of distinct intervention needs for people at different stages, which allows for more targeted and efficient approaches. It also acknowledges those stages before contemplation, which are often overlooked in other theories but are actually critical for many health behaviors. The model is practically applicable across a wide range of behaviors and settings, and it's compatible with other theoretical approaches, which means you can integrate multiple perspectives on behavior change. The PAPM reminds us that behavior change is a process, not just a single event. By recognizing the distinct stages people move through when adopting new precautions, we can design more effective interventions that meet people where they are and help them progress toward healthier behaviors. As health professionals, our goal should be to understand the barriers at each stage and develop strategies to help individuals overcome them, keeping in mind that these barriers differ not only across behaviors, but also across the stages of decision-making for any given behavior.